Good evening and welcome to the first lecture in this, our second year of the series Global Diseases, Voices from the Vanguard. The Voices of the Vanguard series is a joint effort between the Center for Tropical and Emerging Global Diseases and the Knight Chair in Health and Medical Journalism, our own Pat Thomas, of the Grady College of Journalism and Mass Communications, with the assistance this year of the Office of the Provost. I'd like to announce that this is a blue card event, and someone will be here for you to sign in with them, and also people here from People, Parasites, and Plagues should also see Julie Moore or the TA. We hope this lecture series will help solidify the widespread interest in multiple aspects of global health as they occur across the whole UGA campus. Now, we seek to do that by bringing in speakers here to Athens who have both shown through their tenacity and their innovation ways to get about doing something about global health. And I'm pleased that each of you is here tonight. Thank you for coming. If you attended any of last year's lectures, you have some anticipation of what to expect. This year's series will again present a wonderful lineup of those on the front lines of innovations in pursuing global health. All four speakers are visionaries who have been able to blend their factual knowledge with their subject with the realities and the challenges of working in the field. Tonight we're going to be privileged to hear Dr. Eric Ottesen speak to us about the elimination of lymphatic filariasis. Next month, Dr. Zeta Rosenberg will be here from the International Partnership for Microbiocides. And then in March, Dr. Roger Glass will be here, and he's the director of the Fogarty International Center at the NIH. And in April, we'll wind up this year's lecture series, The Voices from the Vanguard, with one of the actual voices. Dick Thompson will be here from the WHO, and he's the spokesperson for the WHO on international infectious disease crises. So we're excited about this entire group of lecturers. And without further ado, I would like to introduce Dr. Sheila Allen, who is the Dean of the College of Veterinary Medicine here, and she's going to introduce Eric. Sheila.
Good evening, ladies and gentlemen. In our ever-changing global society, recent attention has focused on combating naturally occurring and re-emerging infectious diseases that pose major public health threats, including highly pathogenic avian influenza, HIV, E. coli 0157, and others. The responsibility to develop treatments and preventive strategies for these pandemic diseases rests upon the shoulders of scientists. It is my privilege today to introduce Dr. Eric Ottesen, a renowned investigator who has devoted his career to such endeavors. Dr. Ottesen is a research professor and director of Lymphatic Filariasis Support Center at Emory University's Rollins School of Public Health. Dr. Ottesen has spent much of his career leading the fight against lymphatic filariasis, a debilitating condition that affects many people worldwide. Prior to his position at Emory University, Dr. Ottesen spent 7 years at the World Health Organization in Geneva, leading research in filariasis elimination program. He also spent 22 years at the National Institute of Health as an infectious disease scientist and lead investigator in the laboratories of parasitic diseases and clinical investigations. Dr. Ottesen is a Princeton University honor graduate and holds a Doctor of Medicine from Harvard University. Certified by the American Board of Pediatrics, he currently serves on the Task Force for Child Survival and Development at Emory as part of his work on eliminating lymphatic filariasis. Dr. Ottesen is the recipient of numerous awards and honors throughout his career, including a Commendation Medal and Meritorious Service Medal for his public health service at the National Institute of Health, the Donald McKay Medal from the American Society of Tropical Medicine and Hygiene, and the Royal Society of Tropical Medicine, and the Joseph E. Smadel Award from the Infectious Disease Society of America, and the Kitasato Microbial Chemistry Medal from Kitasato Institute in Tokyo, among many others. Dr. Ottesen has numerous journal articles and papers appearing in such publications as the New England Journal of Medicine and the Journal of Infectious Disease. It's an honor for the University of Georgia community to welcome a world-renowned expert of Dr. Ottesen's stature to our campus. Please join me in welcoming a scholar who is internationally recognized and respected expert in the fight against infectious disease, Dr. Eric Ottesen.
Thank you very much, Dr. Allen, for those excessively kind words. I think that probably all of the people that come here and have to speak here must feel a little out of place unless they are have legitimate robed existence, part of the clergy or something. I was thinking, being here, perhaps it'll make the impact of what I say that much greater, but it also makes me make sure that I want to stay close to the truth in anything I say tonight. But anyway, it is a great pleasure to be here. As you'll see later, the University of Georgia has played an enormous role in filariasis research, and I'll come back to that in just a minute. But let me just say first that what we want to do tonight is to really talk about public health, and some of the processes and how the thing works, because we want to make global health experiences, but they have to be experiences around certain topics. And tonight the topic, I think, is going to be lymphatic filariasis, and I think you'll see why. This really is a story of success here, and we have success in the science, we have success in the intervention, and then we have successes that we really didn't even anticipate from filariasis. So let me start with that and first introduce, we got to be talking about something that probably almost nobody here knows much about. Well, we had it working before, there you go. And that is the disease itself. Now, lymphatic filariasis is elephantiasis to most people. And this is lymphedema, where it's really mild, and this is what you see in elephantiasis, where you get these great distended limbs. In fact, though, this is what is characteristically recognized as lymphatic filariasis, but really, the more important one is something we really can't talk about that much because it's just not socially acceptable, but it is men who have similar disabilities, but of the genitalia. It's hydroceles and elephantiasis of the scrotum. It's almost 10 times as common as the lesions in women, but you never see any pictures of it. We really cannot communicate effectively with it because it's just not something that that's easy to bring to audiences. Extremely important, and because it affects the males in the population, has a tremendous economic impact. But what is it that causes these gross distortions, this disease in humans? It's actually little worms. It's these filarial worms that maybe 4 inches long. Filaria means thread-like, so they're relatively thin. But you can see this is a dilated lymphatic. This is at surgery around the hydrocele, from the hydrocele there, where a lymphatic are these very thin vessels that go throughout the body, and the parasites themselves lodge within the vessels and cause dysfunction, so that you end up with fluid that doesn't flow normally, you end up with baggy dilatation, and you end up with problems that have all sorts of complications. And some of those we'll look at in just a couple of minutes. There are other aspects of filarial disease, but we're not going to talk about these things. So that there are a number of different situations, conditions that are caused by filariasis. But again, just the notion that this is something in the lymphatics, causes dilatation, elephantiasis, and hydrocele, that's enough to recognize from a clinical point of view. But the other interesting thing about filariasis is that many people in the endemic areas have no idea that they have filariasis. They don't have those manifestations that you see. Instead, what you can find, or the way you identify it, is that the parasites circulate in the blood. So these are microfilariae. They're much smaller than the adult filaria we saw in the surgical specimen there. And these are white blood cells here, so you can get an idea of the size of one of these filaria. It's something like 300 microns long, circulating by the thousands and thousands in the blood of asymptomatic people. The importance of these things is not immediately to the clinician, but the importance is that this is how the parasite transmits itself and stays, what the life cycle, the endemicity is caused by the microfilaria that are picked up from the blood of individuals, picked up by mosquitoes, and go through a maturation phase, and then reinfect another human, another individual, and then over the course of literally years go through a life cycle that maybe lasts perhaps a year or 6 months or a year on this side of the life cycle, but the adult worms last 4 to 6 years. So this is long, chronic infection, and again, in the tropical areas of the world principally because they have to be transmitted by mosquitoes. Now, why do we focus on lymphatic filariasis tonight, or why do we focus on lymphatic filariasis in general? It's not very well-known disease, as you all appreciate, I'm sure. Well, one is it really causes an enormous health burden, and it affects already more than 120 million people. About 40 million have that overt disease, the elephantiasis, the hydroceles, that kind of thing, and another 80 million have hidden infection. Sometimes they're microfilariamic, like we saw a minute ago, but sometimes you can't even tell that the infection is there. But I'll show you in just a minute what's happening to individuals. But there are over 1 billion people at risk of this infection, so that in the areas where it's endemic, you're talking about almost 1/5 of the world's population. Well, does it make any difference? Well, not if you're living here, of course, but if you're living there, it makes a huge difference. It has an enormous, it's a major cause of disability, stigma, and economic loss in the 83 endemic countries, again, mostly throughout the tropics and the subtropics. As you can see, the tropics and the subtropics. Well, I think the other reason why we focus on filariasis now is that, especially because we can do something about it. Again, this is a good story, and we don't have to sit and suffer with this. In fact, it's a good piece of science. It shows that all of the work that goes on in the laboratories, all of the activities that go on to build this thing, finally do come to fruition sometimes. This is sort of the typical approach to any of the conditions, the infections, the diseases we work on. You know, there are questions that are posed, research is done, get a better understanding of these conditions, develop tools necessary to actually combat them, develop a strategy, how to use that tool, and then somehow get them into the public health sphere where you can make a difference with your public health implementation. And in fact, for those people who deal with the medical sphere, people are always talking about from the bench to the bedside. This is the mantra for researchers, clinical researchers, from the bench to the bedside. But when we deal with these diseases here, we don't really have any bedsides. Very few bedsides in the countries where the disease is endemic, almost nothing here in the U.S. So what we're really talking about is from the bench to the community here. So this is the goal that we have in terms of the development of programs on this global health scale. Now, I want to work through this fairly straightforwardly or fairly quickly. But the important thing is, because this is just a scenario that would apply to almost any of the diseases or any of the conditions we work on. The first step in this thing, though, is really to define what the goal is. Because if everybody's working in a different direction, you say, yeah, we know this is a problem, and we will address this problem, but if everybody has a different view of the problem, then you're not going to get anywhere. So defining a clear goal is the most important first step in all of this. For the filariasis program, the global program to eliminate lymphatic filariasis, the goal had to be two things in terms of that last step for public health implementation. What do we want? We want to be able to interrupt transmission, and we want to alleviate the suffering, prevent the suffering of those who are already affected. So these are our goals. Now, I put that right up front, even though this is the goal of the public health implementation. Let's go back and look at the research components that led to this, or that lead to this. And first, I want to look at that second issue, that alleviating the suffering. It's not going to be the thing that stops the transmission or that eliminates filariasis, but we can't forget the patients. These are the people that are already out there with the infections. We got to do something to help them. Even if we're going to try to prevent others in the future from getting it, what can we do to take care of these patients? Well, there have been some real advances over the past decade and a half in terms of our understanding. This is so important, I think, with all of the science activities that go on here in the academic institution. Pathogenesis, what's happening? It's only after you begin to understand things that you can really address them with a goal, with developing a tool. One of the first bits of understanding we had came from our colleagues at the CDC when they looked in Haiti at young children, and they looked in a way that hadn't ever been looked at young children before. And in fact, what they found was, rather than having this be a disease of older people, because if you look in textbooks or if you have an opportunity to be in an endemic area, really it's just adults that you find with these conditions, with the hydrocele, with the elephantiasis. You almost never see kids with this kind of stuff at all. So you figured it's a disease of old people or of adults. It's not the case, though. In fact, between age 2 and 4 is when they saw the largest increase in individuals who they were looking at antigen positivity. So this was a new test, detecting parasite antigen in the blood. You can't find the parasites there yet. You can if you look, but they're not. It's a lot harder to find. But parasite antigen is given off by the living parasites, and it's between age 2 and 4 that this disease is acquired. So in these countries, it's the kids that are infected, but you don't know about it until they reach the adult stage of life. That was a key bit of our understanding in terms of how to approach this. Another key thing of understanding was the recognition that while these kids are infected, they really have disease. There is something wrong. We just don't see it with our clinical perceiving, our general perception clinically. We have to use lymphoscintigraphy, ultrasound studies. We have to look hard. And in fact, these individuals, these young kids or older people who are totally asymptomatic, don't have lymphatic systems. Now, you remember the lymphatic system it goes throughout the body, and the purpose is to deliver immune cells to infected areas, but it's also to mobilize the fluid so that your legs don't swell at the end of the day. Mobilize the fluid and put it back into the blood system. And what happens, the way it works, there's no pump, of course, not like the heart, but it's really like a set of locks, boats going through a canal with locks. You have valves in the lymphatic tree, and the valves, the muscles squeeze, the fluid goes up, it falls back, the valves close, and it keeps moving up that way. In fact, what happens when you get filariasis is you get great dilatation. These lymphatics get big, fat, dilate, and the valves no longer come together. So the fluid goes up and it just falls right back down. So you end up with, instead of normal lymphatics, this is a radiolabeled tracer going up here as normal lymphatics. This is what the people who have this asymptomatic filariasis have. Great dilatation of their lymphatics and convolutions here, and they don't function well. And if you look at ultrasound, lymphatics are almost totally invisible by ultrasound unless they're enlarged, and here you see a great enlarged lymphatic. So the point was that the second key thing about our understanding the pathogenesis of the disease is that there's a great deal of subclinical disease. Another thing that one of the problems I said, if you have all this fluid coming sloshing back down, instead of being mobilized, it's like your leg becomes a petri dish or a culture medium, so that any little nick, any little problem you have can lead to inflammation. So one thing that is very important is to understand that there are different kinds of the inflammation, and even especially recognizing that it's the bacterial superinfection that gets into the cracks, in the skin, and then gets into those areas of the skin, causes that local inflammation. That destroys more lymphatics. In other words, it turns out to be a vicious cycle. More destroyed lymphatics, more fluid, more infections. That's how you end up with elephantiasis. Well, once this was understood in terms of pathogenesis, then it was not so difficult to figure out, well, how are you going to make these people better? Not just by treating their filaria. You do treat their filaria, but it turns out that if you just apply stringent hygiene, these people do very much better. If we get a little bacteria or fungal infection on our legs, we just wash the thing off. It's really not a bother because our immune system is so effective, and we don't have problems with this. But in these individuals who can't clear it themselves, washing is basically helping their immune system. Just clean things off, make the insult less and less, and so you can end up with a very effective treatment regimen here. And the same story is really the case for hydrocele and genital involvement. So we really do now have some tools that manage patients better, and people feel much better. I can go on and on about this thing, but it's really not. It's not necessary. The important thing is that these individuals can be made to feel a great deal better by applying some very simple tools. And we didn't even understand this 5 or 7 or 8 years ago. It is new finding. Doesn't look remarkable, but it is very, very important to them. But if we're talking about the global program to eliminate filariasis, what we really want to do is not just take care of the people who have the disease, but to prevent it in the first place. So how are we going to do that? We're going to have to interrupt transmission, make it so that there's nothing that's carried by the mosquitoes. Elimination then means that the incidence of infection is 0. Nobody acquires new infection. And for that, transmission from the mosquito to the infected person to the mosquito has to stop. Now this is really interesting. Well, what does it take to make a disease eliminatable? What is it that takes? Some people you'd say, well, it's got to be a certain kind of infection, or it's got to just be in humans, or it's got to be something. But it's very simple. There are only 2 things, and there's nothing biological about whether a disease can be eliminated or not. It's all up to us. If we can identify or create an effective intervention so that we get rid of the thing, that's very important. And we also need an effective diagnostic. And so that if it comes back, we can tell it's there. So it's got to be sensitive diagnostic. It's got to be a very effective intervention. It's only 2 things. I think that's really fascinating. Anything could be gotten rid of if you have effective tools to get rid of it and an effective way to monitor whether it comes back. So again, if we're talking about filariasis, the infection that we're talking about depends on the microfilaria being transmitted from humans to mosquitoes. And very fortunately, there are a number of different drugs that have been developed over the years that are effective against the filaria. Now, in fact, they're not so effective. They're fairly effective against the adult parasites, but they don't kill it completely. But they're extremely effective against microfilariae. And I guess I can stop here and just indicate to you now the University of Georgia has been absolutely critical in the development of this entire story. I could have stopped anywhere and recognized it. But over the past, it's John McCall and Ray Kaplan now who run a filariasis repository, which must be at least 30 years old or something. Just been here at the university for something like 30 years. And they have together produced, John and his team first, and Ray now, have been responsible for producing most of the parasites that have been used in all of the research. And John has done an enormous amount of screening of drugs that have led us to our understanding and capability of using anti-filarial drugs. So when I say it's an honor and a pleasure to be here today, it's really a very significant place for all of the work that's gone on in filariasis. And to maintain this life cycle, it's beyond most people. There would not be any significant filariasis research had it not been for the repository that's the NIH repository that had been here in the University of Georgia for all these years. Okay, so to come back then, basically we have 2 drugs that work very effectively against the microfilaria, 2 drugs that work reasonably effectively against adult worms to shut down microfilarial production. So our best way of breaking the cycle here is to stop these microfilaria, or to get rid of them from the bloodstream of the infected individuals. Each of these drugs alone, if you give a single dose of any one of the 3, brings down the microfilaria counts and keeps them down for periods of at least a year, and even beyond. This is each of the 3 drugs given as a single dose. And you see, that's good, but the real drama comes when you put 2 drugs together. And it's almost a combination of any 2 of the drugs. You can see that the combination of albendazole and ivermectin, which is the combination that's used for Africa, because ivermectin is the drug that says mectizan. It's used for river blindness, major program underway for that. In Africa, we use this combination, albendazole and ivermectin. Look how rapidly a single dose of 2 drugs given together bring the microfilaria counts down to 0. And how long do they stay at 0? We got 30 months after a single dose. That's extraordinary. Albendazole and DEC, which is used in the rest of the world, has a bit of different kinetics. But again, a single dose of the 2 drugs together gets rid of the microfilaria, again, for periods of 2.5 years. Single dose. So that's very impressive. Great tools. Not only do we have the tools for getting effective intervention, we also have a very good diagnostic. I'm not going to go into these filaria that circulate in the blood. They only circulate at night almost. I mean, if you're doing blood studies, you have to go in the night in the middle of the Africa, India, wherever, and sample blood for nighttime. Look under a microscope, see the microfilaria. That didn't work. Nobody was interested in this disease if that's what had to be done. A great step forward came when an antigen, a simple finger prick antigen detection test, allowed you to pick up the infection, recognize that the infection is inside. Parasites are liberating a little bit of antigen, and you can actually detect that immunologically on a simple card test. Extremely valuable. You could not have a program that didn't have the effective diagnostic. You couldn't have a program if you hadn't had the good intervention tools. And I think the other important thing is we don't want to forget we also had tools for managing disease. So it wasn't just the cold epidemiologist going in and trying, we're going to get rid of this thing. It's caring about the individuals who are sick as well. Very important. Okay, well, given all of this then, we've been able to move along this little pathway that we set up right at the beginning in terms of getting better understanding, leading to better tools, and then to figure out how to put this strategy together. And in fact, there's a big difference from what it used to be. In the past, you diagnosed, the thinking was, well, let's go out and find out who's infected and treat them. So that's old-fashioned, nothing complex about that. But it means you have to diagnose all the individuals. You have to screen all the individuals. And then you have to treat the ones that are positive. Very cumbersome. When you're talking about 1 billion people potentially at risk, how are you going to do all of this? It doesn't work. You could not have a program based on this. So the major paradigm shift was think populations. In fact, you might have seen the card test, the cost of it up there, $2.50 each. That's not a public health program. You can't afford that. on the scale of the endemicity of the disease. So you think about diagnosing the population. Just find out where the disease is, and then treat the entire population. One thing I didn't mention about the two drugs, or two things I didn't mention about the drugs that are available, they're extraordinarily non-toxic. Really have almost no problems at all from the drugs themselves. Zero. Put them together, no problems. And in addition, they also kill all sorts of other parasites. The ivermectin, lice and scabies and all the intestinal parasites from the albendazole and so forth. So there's a really good things, really good tools you have, and that allows you to develop a strategy for interrupting transmission by just identifying all the at-risk areas and treating those populations with 2-drug, single-dose regimens once yearly for 4 to 6 years. That was the lifespan of the parasite, or somewhere around the reproductive lifespan of the parasite. And you treat it by mass drug administration so that you're treating everybody in the population. Again, we don't want to forget the second pillar of all of this. We want to alleviate the suffering, prevent the disease. Just take this hygiene story and run it up to a public health dimension. All right, if we have achieved this much, and again, this is where we've done this mostly in an academic sphere so far. These are research issues, these are university issues, these are field trials. This is where we are now. How do we get it into the public health domain? Because this is the real challenge. And in fact, this phase 2 can be a real killer. It makes all the difference in the world how we get from here to here. There's just this is where it takes a lot of skill that is not part of the scientist or the medical health worker sphere here. In fact, it takes a change in the language, and this is where communication becomes absolutely critical. As scientists, medical people, we can talk to ourselves, we can talk about antigens and genomics and pharmacokinetics and interleukins and all of these things that are key in the understanding the pathogenesis, developing the tools and so forth. But it's not going to play anywhere. People won't understand what we're talking about. We got to be talking about partnerships, collaborations, cost effectiveness, the health systems, equity, Millennium Development Goals. I mean, these are not the things that we talk of here in the laboratory. We have to change the language we speak. And here I think it's very important. We don't have to learn this language. We don't have to convert. But we have to have partners who are with us who can make that translation. This is the importance of the communication here that can take our findings and get them into a public health sphere. And what else does it take? Well, it takes commitment of a political nature, the people around you. It takes resources, everybody's going to recognize that, and it takes determination to work together. I think these are the 3 absolutely essential elements that are required in that phase 2 in order to get to the public health implementation. But the political commitment is not just politicians, it's not just ministries of health, it's our scientific colleagues. We have to have our team behind our strategy to move forward. And I think for filariasis, an important thing when it was in 1993 when a task force on disease eradication looked at something like 100 different diseases and identified those for filariasis, the essential criteria for eradicability. Remember, that was having effective tools for intervention, having effective diagnostic tools. They were met. In fact, it's been eliminated in places before. It used to be here in South Carolina. It used to be in New Orleans. It used to be in Australia. It's been eliminated. China is the biggest example of actually going out and eliminating it, and other things. But the point is, it was identified as one of 6 diseases that was eradicable or potentially eradicable. The important thing is the scientific political commitment was there. Now, the other kind of commitment is also very important. The ministries of health, you do have to have politics. You're talking about countries. You're talking about endemic populations. The Ministry of Health has to commit to the notion of all this And for filariasis, the most important thing, and again, this doesn't sound anything like laboratory, it doesn't sound like anything in my experience when I started working at WHO, most important thing of all was getting a World Health Assembly resolution calling on member states to strengthen activities towards eliminating lymphatic filariasis as a public health problem, requesting the Director General of WHO to mobilize support for global and national elimination efforts. Well, what difference does that make? Well, it means that any country you go on, they've all signed on to this. This is now a general world resolution. It's when you go to see them, then it's not a question of convincing them to do something, it's helping them to figure out how to do something. They've already bought into it. Very, very important. All the commitment in the world is not going to get you anywhere without resources, right? Definitely. Big problem. So what do you do? Well, fortunately, we had some very good resources available here. And this is really extraordinary. This is worth, you got to remember, for all the negative things we think about pharmaceutical companies and all the things that pharmaceutical companies don't do right, there are some areas where they are doing some just wonderful things that nobody else is going to do. GlaxoSmithKline agreed to donate all of the albendazole required to eliminate LF as long as it takes. And they also have some other support. Talking about 1 billion people at risk, 4 to 6 years of medicine, once yearly medicine. You're talking about something like 5 billion tablets of albendazole. Now, that's a huge amount of money. In fact, the company is having to build, or has just finished building, a plant in South Africa just to make albendazole to give away. So just to donate these drugs, the drug companies are actually creating a sector of what they do. That doesn't put a halo around them all the time, but let's just be appreciative of what they've done here. Merck is the one who actually started this donation program in the late 80s, giving ivermectin or mectizan for onchocerciasis. And so in all of Africa where onchocerciasis and LF coexist, they donate the ivermectin. The UK government, the Arab Fund for Economic and Social Development, and Japan, these were the key early donors. Since that time, the Bill and Melinda Gates Foundation has also been an important partner in all of this. Now, I think the other thing, though, I want to say, though, we have commitment, we have resources, and what else is really critical here in this phase 2? Well, to me, it's something just like a mantra. Everybody knows in real estate that it's location, location, location. That's the most important thing in real estate. I think if you have anything to take away from the global health business, I would go something like, what's the most important thing in global health? Partnership, partnership, partnership. You can't, in a lab, you can do something by yourself, some things, some experiments, not all of them, some of them. In global health, it's impossible to do anything by yourself. Everything requires partners. The determination to work together as partners. And in fact, when the filariasis thing started, the first strategic plan was actually called the Strategic Plan Building Partnerships for Lymphatic Filariasis. That's what had to be done. Different targets and milestones were set, but the important thing is the roles of each of the partners was written down so that people knew what they needed to do and how they would all fit together in a great plan. And as a result, we have many, many partners, probably in the order of 30 or something, but these are some of the key partners that have played a major role in making this go forward. And in fact, there are different kinds of partners. These public sector partners, we've already talked about the ministries of health and overseas development agencies like USAID and so forth. Private sector partners, the pharmaceutical companies, foundations, the other different NGOs, academia, and then the people partners in the countries themselves. It's extraordinary how many people will volunteer their time, will help out, have an opportunity, they'll take the opportunity and work very hard in the programs and in the communities. So again, partnership at all levels is what's absolutely essential for moving this progression here to the right towards the public health implementation. Now, I don't want to spend too much time on the implementation except to indicate something about what's going on now and just how effective it is. Anticipating a 20-year program, anticipating that much of all of this can be accomplished by 2020. Remember, there are two goals: interrupting transmission, alleviating and preventing suffering. What's an MDA? Well, MDA is mass drug administration. It's those once-yearly interventions. And you have people all over the world, different kinds of ways of getting it, but basically all the communities come together, and you have to treat everybody in the population. That really translates into something like achieving about 80% coverage is very good, if you can get 80%, because you don't treat pregnant women, and you don't treat very sick people, and you don't treat children under the age of 2. But it's extraordinary just how effective you can be in these MDAs. When I say you, it's not people like me. It's people that are the public health implementers in their countries. How they can organize treating a million people in a matter of 2 days, it's just beyond me. It's just amazing how they do it, though. But it really works out very effectively. Again, these are the countries that are involved at different stages of the progression, but I think that the total numbers are really very, very impressive. Between 2000 and 2005, the number of individual treatments, the number of individuals, so this is not cumulative, this is yearly, rose from, say, around 20 million in 2000 to something like almost 400 million in 2005, and the 2006 numbers are not available yet. So we're talking about almost 400 million people have received these two drugs once yearly, and that's really extraordinary. Now, we said before there are 83 endemic countries. Right now the program has reached about 40 of those endemic countries, so there's half to go. Now, what's happening with the results? What kind of results are coming? These are just some sketches that, some plotting of some sentinel sites where these things are being monitored in Egypt, in Papua New Guinea, in Haiti, or in the Pacific island of Vanuatu. These are different sentinel sites, and you can see that the microfilaria reduction is sort of on target, even after 3 of these rounds of MDA, because remember, this is a program that's just begun, but things are really very much on target with the total clearance. Even after 2 or 3 MDAs, almost 45% of the sentinel sites had total clearance of the parasite, totally gone. There is between 50 and 90% clearance occurred in another 40%, and only 13% had less than half their filariasis gotten rid of after just 2 or 3. The point is, it's really going very effectively, and a meeting was held last December with results from maybe 30-some countries, over 750 sentinel sites, and the results are really extraordinary, how effective things are. However, it's on track and doing well, but the important thing to remember is there still are challenges, still problems that need to be faced. And this is really very important. An important part of this first progression that we never saw. I didn't talk about it before. In fact, we've got to recognize that the laboratory scientist's job, or the epidemiologist's backup, the job is not complete just when you move it into the public health sphere. Problems crop up. Better ways of managing things, of doing things, are always needed. Problems have to be fed back in. Same research community has to stay involved in this thing. Otherwise, the program is just going to wilt, because no program is perfect when it starts out. There are all sorts of problems that develop. To combat that, we've had different kinds of meetings together. We've had scientists meet together, identify the challenges, work together, set up plans, WHO, privately. And then most recently, the Gates Foundation has given funds to the Global Alliance to eliminate lymphatic filariasis. To do what? To look at resolving the critical challenges that remain so that we ensure success of this program. Sort of like mid-course corrections. And this is an extraordinarily wise thing, I think, for the Foundation to have done to protect society's investment by making sure that what we're doing is the best that can be done by increasing the research activity. But I think we still have to face the facts here. And the biggest challenge is, in many places, our programs are now starving for funds. That curve that tailed off at 40 because we really can't afford to both increase the treatment areas, the people being treated in the countries where the program's already, and start new programs. There's a real major funding problem. And that's despite the fact that these programs are very well organized, very well run, highly popular with communities, successful in achieving the targets, ridiculously inexpensive, and I'll show you some of that in a minute. And they could be successfully implemented fully if funds were available. So, what do we do to meet this challenge? It's time for a second paradigm shift. Remember, the first paradigm shift was, instead of focusing on the individual, focus on the population. Well, what's the second paradigm shift going to be? It's be taking advantage of what we know is going to work in global health, partnerships. The second paradigm shift, we have to stop thinking about filariasis alone in terms of implementing it. All of what I've told you has only been about filariasis. Advocacy and fundraising. We have to stop just trying to sell filariasis and trying to explain to people. We now have to work with other NTDs, neglected tropical diseases. Filariasis just wasn't a marketable thing. The communication challenges were too great. You could take advocacy and fundraising to a certain level, but it's much more effective if we work with partners and put all of these diseases together as neglected tropical diseases. Now, what are we talking about, and what's the logic? Well, we're talking at a start for lymphatic filariasis, onchocerciasis, schistosomiasis, soil-transmitted worms, trachoma, or all of these diseases. And we won't go into each individual, but the key thing is, how do you treat them? You go into a community one time a year. Maybe twice for the intestinal parasites. But basically, you just go into a community one time a year, give safe drugs, everybody at risk, and leave. So it's very, very similar. You have to define the communities, define what you can give, make sure the drugs don't interact, this kind of thing. But conceptually, they're very, very similar. So there should be able to integrate some of these activities. It's important to remember, though, this is the killer. The devil's in the detail. And so even though it makes a lot of sense to give all of these medicines together, or to get all the people mobilized together, carry all 5 disease cures along with them in logistics, do similar monitoring and evaluation for all these at the same time, link the fundraising and advocacy, there are going to be tremendous challenges in making all of this work. But if the real promise of the future for these neglected tropical diseases is to work together, is to exploit the synergies that one can find with these different public health initiatives that share similar strategies. And these are the different organizations and diseases. Here's Micronutrient Initiative. And in fact, you can put even malaria there. Why? They take bed nets into a community. Bed nets can go in along with this other thing. You bring people together, you increase the distribution of bed nets. There are all sorts of things, the immunization days, the national polio days. There's a lot that can be put together on one platform and moved forward. And I think this is what we recognize as the way forward in terms of both implementation and in resource mobilization. There's a great attractiveness of integrated management of packages of programs. And that way people don't have to memorize, they don't have to remember what were these diseases again. Just know they're the NTDs, the neglected tropical diseases. It's a much better product to sell. And in fact, I'll show you in a minute why it's arguably really the best buy in global health today. And the reason I say that is seen on the next slide, where the comparative costs treatment costs of different key diseases are up here. Now, this is a range of costs down here. The cost per person treated per year in dollars. This is HIV/AIDS. You can see it can be $1,000 and $100 to $1,000, big range. Tuberculosis, malaria, the package of NTDs. Almost all of these are on donated drugs. Onchocerciasis, ivermectin is donated by Merck. Lymphatic filariasis, ALBENDAZOLE by GSK, ivermectin by Merck. Trachoma, azithromycin donated by Pfizer. The soil-transmitted helminths, a lot of them albendazole donated by Johnson & Johnson. All of these products are donated, so what do we pay for in this implementation? We pay for the logistics. Just get the solutions that are already defined to the problem. That's our challenge, and to do it in an integrated fashion makes a lot of sense. So the package of this is really less than 50 cents a year for the whole package of diseases per person. Becomes extremely cost effective. And in fact, this message has actually gotten through to some of the major funding agencies, because when you stop thinking about individual diseases, these neglected tropical diseases, but put them together as diseases of poverty, diseases of the poorest populations, diseases that are keeping people in the cycle of poverty. You put them together, and they also have similar strategies for approaching them, and you compare them to the global disease burden, the DALYs, that are so important in terms of recognizing how important malaria is, the number of millions of DALYs, 46 million DALYs lost, disability-adjusted life years, road traffic accidents, respiratory infections, depression, diarrhea, heart disease. Neglected tropical diseases can hold their own with the importance in terms of the drain on global health. Similarly, if you look at the countries that are affected, they're in different colors here, the yellow being those that have 5 of these neglected tropical diseases. This brownish color, 6 of them. The darker brown, 7 of these. In other words, there's a lot of overlap in the areas of the world where these NTDs exist. As a result, there's a lot of interest and desire to go ahead and do something about this as a package. And in fact, most recently, there's been something formed called a global network for neglected tropical disease control. And it involves most of these major organizations that we talked about before. Task Force for Child Survival is what I'm part of with the Lymphatic Filariasis Support Center. This is also where the Merck's Mectizan donation program is located. It's also where Johnson & Johnson's Mobendazole donation initiative is located. So this has come together as a council which allows greater visibility and actually has begun to turn heads when it comes to support for neglected tropical diseases. And one of the things that I think, again, as from my American point of view, I feel most proud of is that our government, with the USAID this past year, has recognized that it didn't like the individual diseases and supporting them, and it was too confusing. But taking the package of neglected tropical diseases, USAID just put forward $100 million for work over the next 5 years in right now 5 countries, but it's going to continue to expand. It just is beginning, but they recognize they can do a lot for very, very little money, and compared to global costs for things. And Africa is the continent in greatest need. Similarly, there's been a major donation of $8 million from a private foundation in Geneva for Burundi and Rwanda. ExxonMobil just beginning to come in. They're interested. Put some money in Equatorial Guinea, see how it works, and that will grow as well. But people are latching on to this where they couldn't latch on to the individual diseases when communicated. And really there is this buzz on NTDs. I have to think, if you remember, if those of you, Peter Hotez, I think, spoke here last year. This is a slide that Peter Hotez gave to me. But the buzz on NTDs, there's a lot of talk going on now compared to, if they're called neglected tropical diseases, you can imagine how much talk there was before. Now people are talking about it. The new Director General of the World Health Organization is paying attention to the world's paying attention to these diseases, and she's really made a commitment on the behalf of WHO. Jeffrey Sachs, who directs the Earth Institute, you may know of him as a major macroeconomist. Comprehensive Africa-wide control of malaria and the NTDs together would cost no more than $3 billion a year and so forth. Again, he, as an economist, sees the value of these NTDs. The Clinton Global Initiative, which focuses on key issues, chose NTDs this year as one of their key focal points. And in fact, in addition to these others, mentions the importance of these NTDs and the challenges. And of course, the countries themselves are extraordinarily excited about it, knowing that there are tremendous challenges, but knowing that you can also make a difference by approaching them together. So I think the key thing is, instead of, actually, I guess one more thing, there's another, one of the new journals that's being created just for NTDs, one of the Public Library of Science journals. So this obviously is a very prestigious group of journals, and now starting just this year, there'll be a journal, a PLOS journal, on neglected tropical diseases. So I think we have to recognize that in terms of all the successes and challenges, the way forward is going to be to understand that we have extraordinary opportunities to make very, very great impacts on health and economies of the developing world at very low cost. The important thing is we can't do it alone. We got to be working together in these partnerships. So the success will come from exerting flexibility, changing old habits, creating new partnerships and coalitions of coalitions. So we have to bring lots of people together to work. Now that's a good challenge on the human front, but it's something that it's very important, obviously. I think from the way I started the talk, we don't really want to speak anymore just of LF and the global program to eliminate it. And now it's really LF and beyond. It's what we and the NTDs, we can approach the NTDs and other global health problems in this kind of partnership, and stop thinking of filariasis as the elephantiasis and the hydrocele, but really filariasis is just, it's the NTD face. Filariasis is the blind, it's the hydrocele, it's the schistosomiasis, it's the trachoma face. This is the face of poverty, this is the face of the neglected tropical diseases, and this is the face that our new paradigm shift brings us to focus on. That's all. Thank you very much.